Okay.
Saya try dari grup 4.
Kamu lah tak sporting lah. Orang lain semua hantar 2. Hantar 1 je okay lah. Okay, jom.
So case summary pada hari ini. Patient MI, age not mentioned. HO administer IV 10cc chlorohydrate, not prescribed, not labeled. They are withdrawn by MO, not using oral medication syringe to patient MI, called by radio department for CT brain. The patient was crying during infusion and stopped immediately after notice by staff nurse. Crying during infusion and stopped by staff nurse. So cerita dia, patient needs oral chlorohydrate, but due to miscommunication and distractions by staff, was given through IV line. So to identify issues, medicational error, title of incident, wrong route of administration. So untuk buat investigation, team yang diselected from PEDS specialists, PEDS MO, PEDS houseman, staff nurse ward, sister area, pharmacists involved, and medical specialists from different departments.
Sorry, can I ask what was the diagnosis?
Medicational error through wrong route.
The patient was admitted for what?
Not mentioned in our summary.
Or the MI was not myocardial infarction?
The patient's name is MI.
Oh, okay. At least ada orang attentif kat sini Dia kata kenapa ada MI kat sini. Apa nama? Initial.
So plan gathering information, pictures of PEDS ward, IFB ward, interview required by the houseman involved, the MO, staff nurse, documentations from medication slip, patient's file, and from BHIS. Just a run through of sequence. So patient was called to radio for brain plane. MO decided to give chlorohydrate, orally ordered 600 milligrams, which is 50 milligram per kg by Dr. A. Staff nurse informed dose of chlorohydrate is 15 cc and asked Dr. A to prepare, as she was on her rounds preparing and giving medications to other patients. Key person, staff nurse H. So Dr. A passed the chlorohydrate in the syringe to Dr. D, MO, who was in charge of patient MI. Dr. D suddenly received call and passed the chlorohydrate to Dr. J, houseman, with no instruction given. So Dr. J administered IV 10cc of chlorohydrate, which should be oral. So when patient started crying, staff nurse noticed patient was crying and stopped the infusion. So case was informed to pharmacists, feedback given to look out for local reaction, which is tissue necrosis, to watch out for cardiac arrhythmia, CNS depression, and sepsis. Mother was informed by team. Patient was put on close monitoring, and due to the issue, was unable to be sent for CT brain. The plan was KIV to transfer PHDU if any deterioration. Incident was informed to ward consultant 8B. Factors contributing to the problem. This is our fishbone diagram. The incident is a medical error in the route of administration. The task and technology, wrong syringe, unlabeled and unprescribed. Team factor, no communication, there was no proper passover. Management and organization factors, no proper team on administration of drug, lack of staff during that time. External work disturbance, a lot of patients rushing to get CT brain. Work care environment, busy ward. Patient itself factor, patient cannot talk, cannot explain child, baby. Individual staff factors, inexperienced staff houseman. These are the team factors which are involved. Lack of supervision, of monitoring during the course of issue. Ineffective leadership and responsibility at time. Problem in seeking help. So description, verbal communication issue led to miscommunication due to distraction by a phone call by the first MO. A verbal passover between MO to MO and to houseman. There was no written passover not done that caused miscommunication regarding the route of drug administration. Individual factors, there was distraction, there was lapse of concentration, no compliance to protocol, maybe oral medication should be given in a different syringe, there's a personal issue, the person, the houseman itself doesn't know that it's to be given IV, unsafe behavior, assuming, not asking for clarification. Description, inexperienced houseman, first posting, not trained to administer drugs. Patient factor, patient is unable to, cannot talk or explain the symptoms. Task and technology factor, thing is the availability and use of protocols, SOP guidelines, availability and accuracy of health information and others. The syringe was unlabeled for IV or oral and it was not done by the proper person. Unprescribed medication as it was ordered verbally by MO to houseman. Management and organizational factor, resources constraints, no proper team on administration of drug. Same staff nurse who administer drug has to see this. A lack of staff, only one staff nurse attend during the peak hour. Work and environmental factor, noisy, busy surrounding, heavy workload, inadequate break. Busy ward with lack of staff, only one available in ward for drug administration and a lot of distraction including phone call to the first MO. No external factors. So 5 rules of patient, too many personnel involved in administering drug, wrong type of syringe use leading to wrong route of drug administration. Too many personnel involved in administration of oral drugs due to distraction by staff nurse who was supposed to administer drug. MO was distracted by phone call. Caused wrong type of syringe to be used, resulting in IV route of drug administration. Factor 2, untrained staff was asked to prepare the drug, leading to wrong syringe used for oral medication, and the event caused IV route of medication administered to patient. Factor 3, not accessible drug administration or SOP, breach in SOP, wrong route of or route of medication error. Factor 4, no orientation or training regarding drug giving, unaware of the SOP, administration of medication administration error. So the Factor 5, lack of staff nurse to prepare and administer medication, leading to wrong syringe was used by untrained staff to prepare and administer, and event medicational error. So this is a list of root causes. We have 5. Too many personnel involved in drug preparations and administration. Untrained staff was asked to prepare and administer drug. Not accessible medication preparation and administration of SOP. No orientation or training given prior to this event. Lack of staff nurse to prepare and administer medications, leading to wrong syringe was used by untrained staff. So our use is elimination, drug preparation and administration must be done by trained staff nurse. Do not administer unlabeled and unprescribed drugs. Substitution, all drugs must be written with precise dosage and direction of use. All staff must be trained for drug administration. Engineering control, automated electronic health record with computerized physical order, entry example barcode identification, special area for drug dispensing, standardized on equipment or process label all syringe used for oral and IV drugs, labeling, special syringe for oral and compared to IV for drug administration. Administration itself for proper training regarding common medications, dosage and route of administrations. Personal protective equipment. So this is our actions. The strong action is for engineering control using special gown written do not interrupt for those doing drug preparation and administration. And our other action is for oral medications instead of being served in IV syringe to be served in cups. Intermediate actions, more staff to reduce mistake and to reduce the workload in the ward. CME on common drug protocols and rule of administrations, orientation checklist for new staff, drugs preparation checklist, and proper written prescription. Weaker actions is double checks, 2-point identification of dose and route of administration. So our action plan, because the main contribution was restriction by work during drug administration, a special gown for which says do not disturb. The action hierarchy here strong to be person responsible by Sister M, staff nurse H for purchasing of gown, expected completion date 3 months. We try to have a checklist of common drugs, prepare proper checklist, dosage and route for each drug and how it's administered. Action is hierarchy intermediate, person responsible, staff and pharmacists to have a guideline of common drugs in the ward. No double confirmation checklist, double confirmation before drug administration, to have a checklist. Action hierarchy be weaker, responsible person by staff nurse H, evidence of completion, prescription slip in 1 month. Route of drug administration, use special oral feeding syringe if it's not available in the ward to get one. Action hierarchy is strong, person responsible, Sister M, in charge of ward. Evidence of oral feeding syringe purchases to be completed within 3 months. Untrained and inexperienced staff, poor orientation, proper orientation for untrained and new staff. Action hierarchy is here weak, but person responsible from HOD, MO to the houseman in charge and sister for logbook, the monthly evaluation of staff who are new and inexperienced to make sure they are properly oriented. Other is a ratio of staff nurse to patient, which is 1 to 10. This causes overworkload. To increase the staff in the ward, maybe to achieve target 1 in 5. Action hierarchy strong. To get a sister and matron involved, letter of recommendation or to hospital director. Thank you, please.
Saya tahu kenapa semua orang tepuk tangan cepat, sebab nak habis awal. Tapi ada tapi kes ni, kes yang betul kat Selayang. Ni kes Selayang. Lesson learn. Apa yang lesson learn daripada sini? Kosong. Dr. Pravin, apa yang lesson learn? Not learn anything. Is it? What do you guys think? Apa lesson learn daripada kes ni? Sebenarnya kalau tengok balik, satu je, dia ialah wrong route. Salah ubat melalui route mana. So lesson learn sepatutnya apa? Oral. Pakailah oral shrink tu. Okay. So kalau kat sini bagi satu input untuk kes ni. Sebelum kes ni berlaku, PITS dia ada mengalami di mana kalau nak pakai oral shrink, dia orang kena catu. Sebab tak semua budak-budak dia boleh bagi sebab amount of oral shrink tu tak banyak katanya. Jadi with regards to this incident, dia nak benda ni semua ada availability of oral shrink tu di ward masing-masing lah, 8A, 8B, 8C sebab nak bagi oral. So apa saya nak cakap kat sini, dengan adanya insiden benda ni, dia menjadi satu opportunity kepada PITS untuk minta. Sebab dah ada kes. Bila dah ada kes, dia cakap dengan, contohnya kat sini role of HOD specialist dia angkatkan. Bila ada insiden, dia cakap lah dekat dalam meeting-meeting yang bersesuaian, meeting HOD dengan pengarah semua, I want oral shrink must be ready, available kat semua ward. Jadi dia comply dengan PITS dan juga pharmacy. So pharmacy indent benda ni. So sekarang sepatutnya dia dah jadi floor stock. Dia boleh minta, boleh guna pakai. Tak ada istilah catu shrink 5cc boleh guna pakai dekat budak umur 2 tahun. Tak ada. Siapa nak guna pakai, semua orang sepatutnya ada benda tu. Sebab tu saya nak kata buat RCA ni, dia kena doable, feasible dan apa yang kita nak. Just sekarang kita dah tak nak ada orang yang ada masalah wrong route. Sepatutnya bagi orang terbagi IV. So budak ni kalau ikutkan lepas bagi IV, pening dia. Kena monitor. Dan kalau kita tengok balik, kalau sepatutnya safety lock kan, kalau bagi oral shrink dengan IV, sepatutnya kepala dia tak sama. Tapi saya tak tahu macam mana boleh deliver juga benda tu. Okey, macam kita masuk pam minyak kan, betul tak? Pam minyak sepatutnya you pakai pam minyak color kuning, tapi kita masuk diesel. Tak pernah berlaku sebab engineering control, orang yang buat diesel ni nak masuk diesel punya lubang tu, nozzle tu takkan sama untuk kereta-kereta yang tak berguna pakai minyak yang bukan diesel. Jadi tak pernah ada istilah tersalah. Sepatutnya tetapi things can go wrong, kita faham, tapi itulah engineering control. So kat sini jugalah yang saya nak cakap situ, penggunaan oral shrink. Okey, itu satu. Yang lain-lain banyak jugalah. Okey, so anyone mungkin di mana nak comment anything about this case? Sebab pharmacy pun yelah ubat kan. Good.
Kalau orang kau untuk medication kelas lain tak praktis.
Ini the best.
Dia recommended diri. Sebetulnya dia macam medication sampai macam-macam lah. Tujuh je lah. Dia asal dengan banjir.
Ini hujang. Hujang.
Belajar lagi belajar. Mungkin di mana tak tahu sendiri kita ada sister dalam satu sister macam contohnya sister Rosani kata benda tu dah ada dekat orang lain, ini tak ada. So saya pernah nampak like buat pagi ada pakai baju don't disturb. So bila saya nak hantar uniform, don't disturb, saya tak boleh bagi apa-apa kat dia.
For me to outside.
Okay, I just want to comment. There's some great words here. Like, can I know your action plan about like having a proper checklist, right? Like, what type of checklist you want to implement here? And where you want to allocate the checklist, where you want to put? Is it like you want to put the checklist like at every of the BHT of the patient and then before they administer to check? Yeah, we have a dilution protocol every ward, right? So what else you all want to, like, I don't, because I see there's a pharmacy there. So what do you want us to do now?
Kalau dia betul nanti dengan 7
So from our discussion previously, we thought that we put some it's like something that we could put inside the place where we prepare the medication. So the medication which normally and commonly used should have some overdose and also the root of administration. For example, in this case, provided normally orally, but it is IV, so something like that. Just for reminder, especially for the newcomers to the department.
So is syrup chlorohydrate is very common in PITS ward? Or to more to OT cases? So meaning that we have to prepare a checklist about the common medications that usually like how meaning that the route of administration, everything, despite we already have a dilution protocol, that just for as general rules, is it?
Yes. Therefore, especially this case, the hospice, like maybe for the hospice, the person doesn't know like how
learning purposes. I faham sebab kadang-kadang capability group masing-masing dia punya point of view dia nampak daripada benda lain. But mind you that apa yang dah cakap kat sini, bila kita nak meletakkan person responsible, you have to be fair as well. You nak letak siapa, you perlukan sokongan dia, you kena cakap dengan dia. So macam contohnya nak ada checklist tu, fine. Kalau kata pharmacy agree, bolehlah letak. Kalau tidak, it have to be in your culture. Contoh kat sini kan, double confirmation checklist. Sebenarnya kalau bagi kan, isu dekat dengan administration of the drugs, kalau kita tengok among nursing, double confirmation tu memang as a part of the practice. Tak perlu ada checklist lain nak kena tengok, sebab dia memang implement dalam NNA, betul tak? Sebab saya pun tengah tengok benda tu, sebab banyak sangat case. So maksudnya you tak comply to SOP tu sebenarnya. Why? Kenapa tak ikut? Itu yang kita nak tahu. So macam ni kan, double confirmation, kenapa tak ikut? No double confirmation. Nak kata no double confirmation tu dalam administration nursing is there. NNA 5.1 oral administration ada checklist dia. Okey, cuma di peringkat kita, macam kita katalah nursing itu core practice dia, tapi doktor mungkin tak ada checklist dia. Tetapi kita bekerja sebagai satu pasukan. Kalau tak tahu kena tanya. That's why awareness of all this kena tahu. Nursing memang major dia ialah administration. But kalau kata doktor, tak semestinya doktor tak boleh administer. But you have to do what to do before giving and administer the drugs. Of course double confirmation. Sebab dia ada banyak tau. Benda ni dia macam transfusion. Kalau orang boleh pick up satu kesalahan, dia tak akan dapat IV oral chlorohydrate ni. Definitely. Tapi sebab dia one after another, breaching the Swiss cheese model, sampailah budak ni terdapat masuk kat pot yang sepatutnya bukan pot bagi untuk oral hydrochlorohydrate. Macam tu. Doktor Dipan, apa nak tambah?
Umur patient ni berapa tak mention. Okay, but still a pediatric patient kan. So sebab itu juga sebab kita of course kita dah fikir tentang more to structural and other changes supaya kita dapat strong action plan kan. But at the same time kita jangan lupa communication kan. Sebab kalau kita tengok tema patient safety tahun ni kan mencapai diagnosis yang betul untuk patient safety. Last year was engaging with patient. Okay, so by right kita nak bagi ubat dekat patient, kita kena pastikan kita engage dengan betul lah. Apatah lagi patient pitch akan ada caretaker, mother dia. So by right pemberian ubat kita kena explain jugalah. Kita nak bagi ubat ni untuk apa? Sedation, nak buat apa? CT scan ke apa ke kan? So time tu lah healthcare worker sendiri akan tertrigger, akan dapat bantu untuk fikir, kan kita nak bagi sedation, kenapa nak bagi melalui IV chlorohydrate ni? So communication is equally important as well lah. Okay, satu lagi bukan untuk group ni je, untuk semua group, yang saya perasan it's a very good thing lah. Bila kita buat bengkel macam ni, saya tengok semua group yang datang dengan yang come up with action plan berkaitan CME, automatic dia akan letak simulation. So dah tak ada lagi lah. Kalau dulu CME. Sekarang everyone dah develop one step dah jadi better lah letak CME dan apa? Simulation. Okay, cuma saya tak nak kamu hanya bermain dengan kata-kata sahaja dalam RCA report ni, dan pastikan betul-betul come up with a plan. Simulation macam mana yang kita nak buat. For example, tadi group ada group tadi yang dia nak buat apa? Kedua ke group Berdua kot. Okay, yang come up with CME, yang dia nak buat pre and post dan juga berdua lah kan. Okay, so nampak jelas dia nak buat, dia nak bagi training CME, and then simulation ni dia nak buat dalam bentuk pre and post, and then dia nak buat audit. Okay, so nampak jelas apa yang dia nak buat. Contoh macam group yang case radiology ni, tadi ada bagi tahu dia nak buat CME with hands-on kan, with apa tadi? Hands-on lah kan. Jadi hands-on tu macam mana kamu nak buat? Sebab saya rasa daripada suggestion yang kamu dah bagi semua, it could be a good suggestion kalau kita buat macam OSCE. So you can specify CME with OSCE session at the end of the CME session lah. So nampak jelas apa yang kita nak buat. Rather than kita just start hands-on. Saya takut dia akan jadi satu budaya yang salah. Orang dah pandai tulis dah, tapi nak implement tak tahu apa nak implement. Okay, alright. So I think it's a good thing. Thank you.
Boleh kita tengok sequence of table tadi? Okey, ada apa-apa nak, siapa nak komen tak?
Jelas. Jelas lagi bersulung.
Penting kan bila kita tengah siasat ni, kita nak tahulah pada masa ni, hari ni awak buat apa, lepas tu buat apa, lepas tu buat apa. So perlu bahagian komen tu just untuk tolong kita juga untuk highlight apa shortfallnya, apa benda yang kita kena buat lepas ni, apa benda yang kita kena tengok dekat bahagian komen tu. Sebab dia boleh jadi 2 pages ataupun 3 pages. So orang-orang tu kena baca daripada atas sampai bawah. So kalau kita letak highlight dekat komen, so kita boleh tahu after that, lepas ni kita apa benda yang kita kena tengok, shortfall mana yang kita perlu tengok. Untuk grup 4, kalau kita dah buat RCA ni, dah siasat ni, boleh saya tahu apa masalah root cause yang paling utama sekali yang anda kenal pasti untuk masalah ni?
Mungkin masalah communication from one MO to the houseman. Communication.
So root cause yang paling pertama yang awak rasa kena tackle dan paling banyak relate to contributing factors adalah miscommunication.
Yeah.
Miscommunication maksudnya passover.
Yeah, passover. So from Dr. D, they just pass the syringe to Dr. J with no instruction given. So kalau ada instruction, mungkin masalah ni tidak berlaku.
Okay, so orang yang bagi ubat tu, apa kesalahan dia?
Yang bagi ubat didn't rectify or didn't ask, didn't clarify.
If let's say miscommunication, communication dia jelas, Dr. A ke B ke C, dia bagi instruction jelas. So adakah insiden ni tidak akan berlaku?
Kalau communication jelas, tidak berlaku.
Tidak berlaku. Okay, alright. So tadi plan of action untuk miscommunication, Dr. Group 4 buat apa? Ada tak? Ada tak untuk tackle miscommunication? Tak ada. Okay, alright, itu saja. Staff nurse? peti ais, dia kena duduk dalam fridge lah. Okey, so bila nak pakai, contoh kalau dia nak transfer dekat luar. Oh, dah pakai, masuk peti ais. Kalau tak pakai lagi, macamnya dia daripada prep daripada farmasi, boleh duduk luar dulu. Okey, so kalau kata dah duduk dalam peti ais, kalau nak guna pakai untuk orang lain, boleh pakai balik lah. Okey, baik-baik. Alright, terima kasih banyak guru 4. Okey, thank you. Alright, okey. Tadi cepat tanya. Dia bukan senang, saya faham. Okey, tapi itulah bendanya. So macam contoh, macam doktor kata,